Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs.
Hello, everyone. Welcome to our program today. This is Emily Brown, the Program Director at Cancer Support Community Atlanta. Thank you for joining us today for this program on genetic counseling for cancer with Tim Hakim. He is a licensed and board-certified genetic counselor specializing in hereditary cancer and joined the Northside Hospital Cancer Institute in the summer of 2021. And he is also originally from Arizona. So thank you, Tim, for doing this program for us today, and I will hand it over to you.
Thank you for having me, Emily. So just to get started, I wanted to highlight what I'll be covering today so you know what to expect. So I'll start off by answering the question, what is the connection between cancer and genetics? Because I think that that's not always very obvious or intuitive. And then what are some of the clues that there might be a hereditary predisposition to cancer in someone's family? What does a genetic counseling appointment entail? What are some of the benefits of genetic counseling and genetic testing? How could genetic testing change medical management for someone? And then we'll have some time at the end for questions and answers. And if you have any questions kind of relevant to the slides as I'm going through, then feel free to put those in the chat and Emily will be monitoring those. And then if you have other questions, yeah, just feel free to save those for the end. So what is the connection between cancer and genetics? So all cancer is genetic, but not all cancer is necessarily hereditary. And so when I say that all cancer is genetic, what I mean is that cancer is caused by changes or mutations that happen in our genes. Genes are the instructions that tell cells how to grow, how to function, basically how to keep us alive and keep ourselves from becoming cancerous. And so in most cases of cancer, those changes are things that happen over someone's lifetime, damage that occurs in our genes after someone's born. They're not inherited. We have about 100 different genes that keep us from getting cancer. So that would include things like BRCA1 and BRCA2, if you've heard of those before, as well as a lot of other genes that don't get as much headlines or press, but are also really important for keeping us from developing cancer. And in particular, when those particular genes develop mutations in them, that's when someone could develop a cancer. So, and really we think of these as cancer genes, but they're probably better called anti-cancer genes because the function of BRCA1 and BRCA2 and other genes is to keep us from getting cancer. So in most cases of cancer, what we'd call sporadic cases of cancer, someone's born with two working copies of a particular gene, one that you would have inherited from your mom, one that you inherit from your dad. And then just by chance, at some point, one of those two copies develops a mutation in it for whatever reason. Many times we don't necessarily know what's causing the damage in the gene or that mutation. Sometimes we know of particular risk factors like smoking or sun exposure, especially with lung cancer or skin cancer in particular. But many times we don't necessarily know what's causing that damage. And then in the same cell at some point, maybe I should just take a step back and say, you know, if a single cell develops a mutation in one of the two copies of a particular anti-cancer gene, that's okay because that cell still has a backup copy of that gene. So if if we're talking about BRCA1, for example, then you still have that cell still has a functioning copy of BRCA1. It's only if that same cell was to develop by chance a second chance mutation in the other copy of BRCA1 that neither copy of that gene would be working any longer, and then BRCA1 is no longer able to do its function of repairing damage in the cell, repairing other mutations that happen in other genes. And so more and more mutations could start accumulating until that cell potentially becomes cancerous. So that's most cases of cancer, what we call sporadic, two chance mutations in each copy of the same gene in the same cell leading to cancer. When someone has a hereditary predisposition to cancer, what that means is that they're born with one of those two copies not working. And that could be inherited from either their mom or from their dad. And so because of that, for someone who has a hereditary predisposition to cancer, they only have to have one chance mutation instead of two in a particular cell in order to develop cancer potentially. So when we do genetic testing in people who have cancer, so not the general population, but when we specifically do genetic testing in someone who has cancer, we find that about 1 in 8 people has some sort of hereditary predisposition. Typically, that predisposition is the type of cancer that they have, but we could be doing genetic testing in someone who has breast cancer and then incidentally find out that they have some sort of increased risk or predisposition to colon cancer, for example. So, but we think that about 10 to 15% of cancer we classify as hereditary, where there's a hereditary inherited predisposition, a mutation in a single gene that's causing that. We estimate that about 70% of cancer is sporadic, meaning it just happens by chance. This would be like an isolated case of breast cancer or an isolated case of colon cancer or some other kind of cancer. And then in another 15 to 20% of people, we see that there's a family pattern of cancer, maybe multiple people with breast cancer, but nothing that we can determine when doing genetic testing, nothing that we can find through our current genetic testing. So it could be that there's other things going on there. It could be that there's other genetic risk factors that we don't know about or we can't measure well at this point in time, or there could be shared environment, shared lifestyle, similar exposures that explain those familial cases of cancer. So what are some of the clues, some of the hints that would tell us that there might be a hereditary predisposition in someone? So one of the key things is when we see cancer at an early age, we roughly define this as under the age of 50. When we see multiple cases of the same or related kinds of cancers in the same person or in multiple family members, particularly on one side of the family. So if you have multiple cases of breast cancer on one side of the family, we know that certain cancers can be caused by mutations in the same genes. So oftentimes the same things that can cause breast cancer can also cause ovarian cancer, pancreatic cancer, prostate cancer. Some of the things that can cause colon cancer can also cause endometrial cancer and some other kinds of cancer. So when we see clustering of similar kinds of cancer or things that we know can be caused by mutations in the same genes, that can be a suspicion. If we see multiple generations affected with these same or similar kinds of cancers, rare kinds of cancers like male breast cancer or pheochromocytomas. And then we also know that for whatever reason, there's certain genes for people of Ashkenazi Jewish ancestry, they have a slightly higher risk than the general population for having a hereditary predisposition to cancer. So when should someone consider genetic counseling and or genetic testing? So a lot of it is what I just covered, early ages of cancer, multiple similar cancers. Many people had prior genetic testing for BRCA1 and 2 for just these two genes. And it used to be that if someone had breast cancer that was suspicious, they might be tested for just these two genes, but not tested for other things. And there's a lot of other genes that we know of now that can also cause an increased risk for breast cancer in particular. And so, but up until about 2013, a lot of testing that was being done was just BRCA1 and BRCA2. And that changed in 2013 due to a Supreme Court ruling. There was one lab that had a patent on sequencing those two genes, and they lost that patent. And very quickly, a lot of other labs started offering genetic testing, doing broader panels of multiple genes all at once and for much lower prices. So that really increased the access to a lot of genetic testing as the price came down. As the price came down, it also meant that insurance companies were more willing to pay for it. And then as a result of that, a lot of the criteria for recommending when to do genetic testing or when it will be covered by insurance has gotten looser and much more easy to meet because the cost has come down. And then also, I think it's good to consider genetic counseling, genetic testing anytime you have what I call golden ticket genetic testing scenarios. So these are scenarios where it's an automatic recommendation from the National Comprehensive Cancer Network for genetic counseling and genetic testing. So what are some of those golden tickets to genetic testing? So the National Comprehensive Cancer Network, or NCCN, has guidelines for everything related to cancer, and including when to do genetic testing. And so some of the scenarios that they recommend when to do genetic testing are when someone has breast cancer at 45 or younger, or if someone has breast cancer from a little older than that, 46 to 50, and has one other relative with breast, ovarian, prostate, or pancreatic cancer at any age, triple negative, metastatic, and male breast cancer at any age, ovarian cancer at any age, pancreatic cancer at any age, colon or rectal cancer, colorectal cancer at under the age of 50, endometrial or uterine cancer under the age of 50, prostate cancer that's metastatic, or this gets into some technical details, but high or very high risk groups, or prostate cancer in someone who has Ashkenazi Jewish ancestry, Ashkenazi Jewish ancestry in breast or prostate cancer at any age, and then renal cancer or kidney cancer at 46 or younger. And in addition to all of that, I have these asterisks here. If you have a family member, a first or second degree relative, who meets any of these who meets the criteria with the 2 stars, then they also would meet the guidelines for recommending genetic testing. So a first or second degree relative, so if your grandmother had breast cancer at 45 or younger, for example, or if you had an aunt who had ovarian cancer at any age. Some of these, for like colon cancer, uterine cancer, it has to be a first degree relative in order to also meet the guidelines. And then there's also, I should say, there's lots of other ways to meet the guidelines. So if there's 3 or more breast cancers in a family, then someone will likely meet guidelines, even if they're at older ages. So there's lots of other combinations of ways to get there. So what does a genetic counseling appointment entail? So typically we'll start off by reviewing someone's personal and family history. We'll draw a pedigree or a family tree to document the family structure, the ages of people, either current ages or how old they were when they passed away, anyone who's had a cancer diagnosis. And then I like to do a risk assessment after collecting personal and family history and drawing out the pedigree. And the 2 questions that I like to ask are, how suspicious does someone's personal and family history look of a hereditary cancer predisposition? And so that's a fairly subjective question. And then more objectively, does the patient meet NCCN guidelines for recommending genetic testing? Oftentimes, insurance companies follow somewhat closely the NCCN guidelines. So if someone meets the NCCN guidelines for recommending genetic testing, oftentimes it'll be covered by their insurance. And then I'll also do some of the things that we've already done today, explain the background genetics of cancer, reviewing the benefits and drawbacks of genetic testing, and then going into the different options for how to actually do the genetic testing. So what is the benefit for someone of doing genetic counseling with or without doing genetic testing? So in genetics, we like to answer, there's 2 questions that we like to answer in genetics. One is why something happened, and the second is what to do about it. And so hopefully we can give an answer to the why question of why someone had cancer at a younger age, or why there's multiple breast cancers or colon cancers or whatnot. And then what to do about it. And one of the things that I really like about cancer genetics is that there's so much that we can do in terms of changing medical management and informing care for the patient, but also for other family members. Genetic testing and genetic counseling can help us better define cancer risk, whether that's higher or lower. And many times people have a high sense of risk, of their cancer risk, because they've seen a family member who's had cancer. And so that's had a really strong impact on them. And so in some situations, it can be helpful to look at their family history, their personal history, and then determine, what is that risk likely to be? And in many cases, it's lower than they think it is. And then as well, genetic testing can help clarify that risk, higher or lower. And then what are the chances of other people in the family also being affected or having that same hereditary risk? Determining what cancer screenings are appropriate, and then if there's any preventative surgeries that would be recommended or not, depending on the type of cancer and what was found through genetic testing. So there's a lot of different things that could be found with genetic testing, and just focusing in on breast cancer specifically, there's about 13 different genes that we know of that can increase the risk for breast cancer. And so this is just a few of those genes. The two, like I said, that are the most well-known and probably represent about half of cases of hereditary breast cancer are BRCA1 and 2. And this chart shows a range of risk for those. Usually I estimate it's around a 70% lifetime risk for breast cancer if you have a mutation in one of these two genes, compared to the general population risk of breast cancer in women, which is around 12 to 13%. There's some other genes that also have a fairly high risk for lifetime risk for breast cancer. And then there's some that have a more moderate risk. So one of the more common ones is called CHEK2. We think that it's about a 20 to 40% lifetime risk for someone who has a mutation in that to develop breast cancer. And this just breaks that down. This is from a particular lab that offers a 25 gene panel that looks at genes related to breast cancer, but also includes other common hereditary causes of cancer. And so when testing someone with a personal history of breast cancer, for those who test positive, so it's not everyone who's going to test positive, but for those who test positive, when they test positive, about half of those, half of the positive results are in BRCA1 and 2 specifically. There's a small handful of other high-risk genes, and then moderate risk genes are about 38%. So that would include things like CHEK2, ATM. And then sometimes incidentally, we find other mutations. So someone has a history of breast cancer, but we find incidentally that they have a mutation in a gene related to colon cancer, for example. And so what do we do with this information from genetic testing? So I think it's helpful to do what's called risk stratification and figure out where does someone fall in terms of risk. So, for someone who's at average risk, general population risk for breast cancer is around 13%. The guidelines are to start doing annual mammograms at age 40, in addition to self-breast exams and clinical breast exams. When someone is estimated to have an increased risk for breast cancer of 20% or more, then there's some increased screening that is recommended. So annual mammogram, but also with consideration of doing 3D mammogram instead of just regular mammogram, and then also adding an annual breast MRI. So oftentimes someone would have a 3D mammogram in January, and then in July they might have an annual breast MRI. So alternating between those two, so they're having some sort of screening every 6 months. And that typically would start at age 40. So the same age as the general population, but we're doing more screening and more in depth. This is also helpful because if someone meets these guidelines for being determined to be at increased risk, then oftentimes that will be useful for justifying insurance paying for something like a breast MRI or a 3D mammogram instead of just regular mammogram. You could get to that 20% increased risk because you test positive for a moderate risk gene like CHEK2 or ATM. But also importantly, I think that we can do risk models, even for someone who tests negative or doesn't have genetic testing. And we can look at their personal history, their personal risk factors, and their family history and estimate what their lifetime risk for breast cancer is and give a personalized risk score to a woman. And if that number is over 20%, then that's going to have a similar management effect as testing positive for a moderate risk gene, like a mutation in CHEK2. And then for those people who have one of those high risk, very high risk mutations in a gene like BRCA1 or BRCA2, we're going to also be doing that same increased screening of 3D mammogram and breast MRI, but we're going to be starting that a lot sooner at age 25. And then there's also recommendations for considering risk reducing mastectomy and also risk reducing removal of ovaries after someone's done having children. So depending on where someone falls in this risk, it changes the medical management recommendations.
Tim, we have had 2 questions come in the chat box if you're ready.
Sure.
One, I think you're probably going to get into a little bit later, but just somebody wondering if you can be refused any type of coverage based on genetic testing and results, insurance or long-term disability.
Yeah, that's a great question. So there's a 2008 law called GINA, or the Genetic Information Non-Discrimination Act, that prohibits discrimination in most cases for health insurance or for employment. There's some exceptions for small employers and other situations, but generally you can't be discriminated against for health insurance or for employment purposes. But there is not protection for life insurance, long-term care, disability insurance. So especially for someone who is maybe younger, in their 20s or 30s, and in a position where they would maybe want or be thinking about getting life insurance, oftentimes I'll recommend that they get their life insurance in place before doing any genetic testing, because their genetic test results would become part of their medical record, and anything in their medical record could be used to deny them coverage or to charge them more for life insurance, long-term care, disability insurance, those sorts of things.
Interesting. Okay, definitely something to consider. How about another question? What about first-degree cousins? I didn't see them in the list. Would having a cousin with cancer increase your risk?
So it would slightly. So a first cousin, so your aunt or uncle's child, would be a third-degree relative, and so you would share 12.5% of your DNA with a first cousin. You share 25% of your DNA with a second-degree relative, like an aunt or uncle and grandparent, and then you share 50% of your DNA with your parent. So it could increase your risk slightly, but as you get further and further out, you're sharing less of your DNA with that person, so it's going to have less of an impact on your risk. But the good thing about genetic testing is if we can determine what is causing that. So if there was a cousin who had breast cancer at a young age or ovarian cancer, and then they were to test positive for a specific mutation, like a BRCA2 mutation, then we could do genetic testing to see if you have that mutation or not. And then it's an either or. So it's not a blending, it's an either or. Either you do have that very large risk or you don't have that very large risk.
All right, thank you.
Yeah. Were there any other questions at this point?
I don't see any other questions. I did want to mention though, if somebody has a concern about a family member, we are recording this program today, and if you wanted to share it with somebody, we will have it posted on our website. If they weren't able to join, or you just think this is information they could benefit from, we'll definitely be able to share that with you.
Yeah, that would be great. So I wanted to give a hypothetical person, a fictitious person that comes in, a 26-year-old female named Kimberly, who has a paternal family history of breast and ovarian cancer. So this is a pedigree that we would draw. The circles are females, the squares are males. And so this is Kimberly. She has a daughter and a son, and also a sister and a brother. Her dad's sister, her aunt, Julie, had ovarian cancer and passed away at 58. Her dad's sister, her aunt, Gloria, also had breast cancer at age 42 and is still living at age 47. And then her grandmother on her dad's side had breast cancer in her 40s, and then later had ovarian cancer in her 80s. And so the question that she would be coming in with is, what is her risk for breast cancer? What is her risk for ovarian cancer and other cancers? So certainly this is very concerning, and you could understand, her having a lot of worry about that. So we could do a risk estimate, even without any genetic testing, to estimate what her lifetime risk would be for breast cancer as well as ovarian cancer, as well, and also her chance of testing positive for BRCA1 and 2 specifically. So this family history would be strongly suggestive of a BRCA1 or a BRCA2 mutation. So one of the better risk models, there's various risk models that'll give different risk estimates, but one of the better risk models is the Tyrer-Cuzick. This brown line at version 8 is, I think, one of the better ones. And so it's estimating about a 23% lifetime risk for breast cancer based on Kimberly's family history and also personal risk factors, which I went in and added, like her pregnancy history and breast density and things like that. And then it also is estimating about a 14% lifetime risk for ovarian cancer. And it also estimates that she has about a 22% estimated chance of her testing positive for a BRCA1 or 2 mutation, which might seem low given the really strong family history. But even if we knew, you have to know that even if we knew for certain that her grandmother, and I'll just go back to the family tree, the pedigree, even if we knew for sure that her grandmother had a BRCA2 mutation, for example, there's a 50% chance of that being passed on for her dad, but also for each of her siblings, or her aunts and uncles, I should say, sorry, her dad's siblings. And so it very well could be that Gloria and Julie inherited that, but that Roy didn't. Or if Roy did, there'd be a 50% chance of that being passed on to Kimberly. So without knowing, even if we knew with 100% certainty of her grandmother testing positive for a BRCA2 mutation or having a BRCA2 mutation, her likelihood of testing positive would be 25%. If her dad was to test positive, the likelihood of her testing positive would be 50%. So even though this is a very strong family history, it's more likely that she tests negative than that she tests positive. So based on her, let me go back. Based on her having, at this point, a 23% lifetime risk for breast cancer, she would meet the NCCN guidelines for considering her at increased risk. So just based on that, the recommendation would be for her to start having breast MRIs, annual breast MRIs, and annual mammograms, at least starting at age, well, typically we would say at age 40, but because she has a family history with her aunt with breast cancer at a younger age, she would probably start in her a little bit sooner than 40. And so she would be considered, she would fall into this increased risk based on where she's at right now in terms of not knowing anything about genetic testing or if anyone's testing positive. Now, if she was to have genetic testing and then test positive, all of a sudden her risk for breast cancer would shoot up to about 65%. So much, much higher, and her risk for ovarian cancer would go much, much higher. And we would also know that there's a 50% chance for her children to each test positive, to inherit that mutation, have those risks, particularly for her daughter. And for her siblings as well, there's a 50% chance of them having inherited that mutation, that same mutation that she has. And so now, instead of starting at age 40, we would recommend starting the breast MRIs and 3D mammograms at age 25. And really what we would be doing is we'd be referring that person to a high-risk breast surgeon or breast doctor who's going to customize what that screening looks like for Kimberly, because it may be that ultrasounds would be better than mammograms for various reasons. Now, if she was to test negative, where does that put us? Basically, if she was to test negative, it would put her it would lower her 23% number slightly, but it would lower it probably to not very much. Like, it probably would still be over 20%. And the reason for that is, with her testing negative, we don't know if Kimberly's testing negative because there's nothing in the family that can be found with genetic testing, or is she testing negative because there is something hereditary going on from a cancer predisposition perspective, but it wasn't inherited by her. So either it wasn't inherited by her father, so it never was passed on to her, or it was inherited by her father, but she didn't inherit it. So a negative result in Kimberly, without any genetic testing in her family members, we would consider it an uninformative negative. So that's one of the potential ambiguities that can come out of genetic testing, is sometimes we don't have a clear answer for what's going on. And even with negative genetic testing, it wouldn't necessarily change her medical management. However, if her aunt was to get genetic testing and her aunt was to test positive, and then for, say, a BRCA2 mutation, something that would explain the family history of breast and ovarian cancer, and then Kimberly was to test negative, then we would know what's causing the breast and ovarian cancer in the family, and we would be able to say that Kimberly doesn't have that same genetic risk factor, and so she's likely going to be, instead of being in this increased risk category, we could then lower her to something closer to average risk for breast cancer as well as for ovarian cancer. So that's where genetic testing can be most helpful, is if we can test someone who's affected. If we do find a mutation in the family, then any negative genetic testing for someone like Kimberly has a lot more context and becomes much more helpful. So what questions do people have?
All right, the questions have been flowing in, so let me scroll up. I know we had one individual who is living with stage 4 lung cancer, and recently I think they discovered a mass that is believed to be benign, but this person had a grandmother with breast cancer as well as a great aunt who passed away with breast cancer. Should she still get tested?
So it would depend on the ages. It would depend on the ages. Typically, so if it was her grandmother who had breast cancer, if it was, and then that grandmother had a sister who had breast cancer, that would get us to 2 people with breast cancer, assuming that those are over the age of 51 and older. If there was one more person on that side of the family with prostate cancer at any age or breast cancer, then yes, she would meet the guidelines for recommending genetic testing. So that's one of those kind of gray areas where she could be referred to a genetic counselor and we could go through it a little bit more in depth to figure out.
Okay. How about someone with DCIS, but no other family history, no one else in the family has had cancer? Would you recommend testing for them?
So in terms of the guidelines, we recommend DCIS or ductal carcinoma in situ is treated the same in terms of a breast cancer diagnosis. It would really depend on the age of diagnosis. So if they were under the age of 50, then I would say consider it. If they were 45 or younger, then we would definitely recommend it. Because there can be all sorts of different ways that there could be a hereditary predisposition that doesn't show up in other family members, like if it was coming from dad's side of the family. And so
they're saying 61. I guess that's their age.
I think if it's an isolated case of breast cancer at 61 with no other family history of breast cancer or ovarian cancer or pancreatic cancer or prostate cancer, then no, I don't think that they would need genetic testing probably.
Okay.
But they could. So let me kind of add on to that though, that there's definitely a lot of thought, a lot of discussion about doing genetic testing for anyone with breast cancer. And so even though she may not meet the NCCN guidelines, there's some people who think that it would still be worth doing. If it's not covered by insurance, then the labs that we work with have a self-pay price of $250. So if they were interested, they could still do it and pay for it out of pocket for $250, which is much, much cheaper than it used to be.
Wonderful. Okay. Here's a question. I don't know if you'll be able to answer this, but someone's wondering about the prevalence of breast cancer now. They heard that now it could be 1 in every 4 women will develop breast cancer. Have you heard anything about that, or can you speak to that at all?
I have not heard about 1 in 4 specifically. I have heard that the rate of breast cancer is increasing, but I don't have any good numbers on that.
Okay.
The number I usually use is 13%. Some of the older numbers are more like 10%.
Someone asked that the out-of-pocket cost you were talking about, the $250, is that full panel testing or just BRCA?
That could be full panel testing, yeah.
And can you speak?
And to clarify,
go ahead.
I was just going to say that oftentimes we do broader panels now. So with one of the labs that's common hereditary causes of cancer is a 47 gene panel that covers breast cancer, ovarian cancer, colon cancer, or hereditary causes of those types of cancers. And then they have a 84 gene panel that would cover common and less common hereditary causes of cancer, including a lot of rare or hereditary cancer syndromes. So yeah, the 250 would cover all of those.
All right. Can you speak at all to the emotional distress people might associate with getting genetic counseling, or how you would talk to someone who's having who has questions about whether or not they should get counseling and concerns about what they might find out?
Yeah, certainly it can be really difficult, especially if they have a kind of if they're in the middle of that with their own personal diagnosis of breast cancer or another kind of cancer, or family history. A lot of the people that I talk to have cared for their mom going through breast cancer, for example, or another close relative. So there's a strong impact there. I think it's good to remember that that generally genetics isn't destiny. So even if you have a high risk mutation like a BRCA1 or BRCA2 mutation, it's not 100% lifetime risk for breast cancer. And there's benefit in knowing early in terms of increased screening. So, and not that anyone would be forced to do a preventative surgery, and that can obviously be a complicated decision. But there's ways to reduce the risk for breast cancer with mastectomy, and ovarian cancer, with removing ovaries when you're done having children. So I think that knowledge can be empowering to know what that risk is and ways to mitigate that. The best kind of cancer is a type of cancer that you never have because of if you've had a preventative surgery, for example, to reduce the risk. And then the second best kind of cancer is one that you catch really, really early because of increased screening. So knowing what the risk is and then making those appropriate changes to medical management can be really helpful for changing the narrative.
Absolutely. Thank you for speaking to that. One participant has an interesting situation. My daughters are identical twins. Would results from genetic testing most likely be the same for both and possibly avoid the need for one of them to be tested?
Yes. So if they're identical twins, then their genetic testing should be the same.
You just have to pick which twin.
Yeah. And if you're trying to pick, and I don't know the full situation, I would also say too that the best person to test in the family may not be one of the twins. It may be the mom or the dad or whoever's closest to either the affected person with cancer or the closest person to the person with cancer. So.
All right, and someone's asking for contact information, how they get in touch with Northside Genetic Counseling.
Yeah, that is a great question. I always forget our phone number. Let me. I have it on my papers, but I moved it.
Yeah, while you look for that, I'll just let everyone know we
Okay.
are going to have another education program next week on precision medicine with Dr. Bordoni, who's a medical oncologist with Georgia Cancer Specialist. So again, the topic is precision medicine. And if you're curious as to what precision medicine is, I invite you to join us next Friday, March 4th, I believe, at noon. And you can find out more information on our website, cscatlanta.org.
And thanks for giving me a little time there. So our office, the phone number is 404-851-6284. 404-851-6284. And then you can also reach us at genetics@northside.com.
All right, thank you for sharing that. Let me know if you have any further questions. I'm not seeing any more in the chat. Tim, thank you so much for providing this opportunity for us, taking the time out of your day to share this information. This is really important information to get out to the public, so I'm grateful for you doing this for us today. And I think we're going to try to do quarterly programs with genetic counselors just to make sure that all the patients and their family members are staying informed about any new developments in genetic counseling. Do you have any ideas to what is the wait time if someone tries to call and make an appointment with a genetic counselor, if they need to go ahead and schedule it soon?
Yeah. Our wait times are probably around 5 to 6 months right now for typical referrals. So that would be if someone is not affected with cancer currently, but has a family history.
Okay.
And then we do try to see our stat patients sooner. So if someone has a recent diagnosis, especially if it's going to change medical management or their treatment or surgery decisions, things like that, we try to get those patients seen in a week or two. And the best, we require a doctor's referral. So that could be just your OBGYN or primary care physician. So that's the best route, is to talk to your doctor, and then they can someone can be referred to us that way. And you can also, of course, call or email us, and we can kind of get you that information to give to your doctor.
All right, wonderful. Well, we're getting some great feedback in the chat. Wonderful presentation. Thank you so much. Again, everyone, this program was recorded today and will be available on our website, cscatlanta.org, in the coming weeks. So we invite you to check that out on our website. And thank you again, Tim, for taking the time to do this for us today.
Sure, it's my pleasure.
All right, everyone, have a wonderful rest of your day.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.